I watched a surgeon spend 45 minutes on a video call doing what should have taken 8 minutes of asynchronous review. The patient sent photos, the imaging was already uploaded, the history was in the chart. But we've trained an entire generation of clinicians to believe that care only counts if there's a camera involved. Welcome back to The Clinical Realist. I'm Dr. Sarah Matt. And if you listened to our last episode, you know we mapped out the castle in the field, the world-class medical centers and everything outside of them. Today, we're talking about the infrastructure that actually connects those two worlds. And spoiler alert, it's not the video visit. So here's what happened in March 2020. The pandemic forced us into virtual care overnight. Within 4 weeks, we had more telehealth encounters in the United States than we'd had in the previous 10 years. We didn't design virtual care from first principles. We replicated the office visit on a screen. So think about what that means. An office visit is fundamentally inefficient. You come at 2 on a Tuesday because that's what's in the schedule, and you wait. You see the clinician for 12 minutes max, you leave, you get a bill. That model only works if you're in the same location. The moment you move it to a screen, you've thrown away the one thing that justified the inefficiency, the human proximity. And yet, we did exactly that. We took Zoom, we put the office visit on it, and we called it a revolution. But here's the thing that's interesting. While we all were celebrating video visits, something else was happening. Some health systems, not many, but some, started experimenting with what virtual care could actually be if you designed it for the medium instead of just copying what came before. And those experiments, they worked. I've spent years and years as a surgeon and as a provider. I've worked as an EMT. I've done rural medicine in places where your choice is video or nothing. And I can tell you from that experience, the video visit is the least useful thing virtual care can do. It's the training wheels. It's the step before the real innovation happens. So what is that real innovation? If we think about it against the 5 pillars we talk about in the book, because of course they're the best framework I know of. First, let's think about asynchronous care. A patient in Atlanta sends a photo of a surgical wound, say at 11 p.m. on a Saturday. Nobody's in the office. Nobody's on call for this. But the photos are automatically classified by AI triage and classified as non-urgent. Surgical team sees them first thing Monday morning. By 8 a.m., the patient has a treatment plan. No video call needed. No delay in getting to the right clinical decision. That's real virtual care. Second, AI triage that actually works. So in a traditional system, if you think you might need a specialty care appointment, you call your primary care doctor, they refer you. The specialty office puts you on a waiting list, and maybe 60 days later, you get an appointment with someone who might be able to help you or might just hand you off to someone else. And meanwhile, you're either getting worse or you've given up. The Medicare App Store that CMS just announced, 47 million beneficiaries are eligible, supposed to change this. But here's attention. About 25% of those beneficiaries are 75 or older. You're not downloading an app. And honestly, no one wants another app, no matter how old they are. So what should we be doing? Maybe the patient just describes symptoms through a simple text interface. AI routes them to the right specialty within 48 hours. And the first clinician they see is actually equipped to help them. No intermediaries, no waiting. Third, continuous remote monitoring that catches decompensation before the crisis. So we've all heard stories about congestive heart failure in remote locations. They have a really hard time seeing a doctor every 3 months. But with simple blood pressure monitoring that they can use at home, all of a sudden when BP spikes or weight suddenly jumps, intervention can occur. This can prevent an ER visit. This can prevent an admission. And it can prevent a death that probably would have happened. And that's not new technology. That's just old technology used intelligently. So now imagine that with real-time data streams, machine learning, algorithms, and clinicians trained on how to actually respond to continuous data instead of only episodic snapshots. The pandemic forced us to ask, how do we deliver care remotely? What we should have been asking is, what becomes possible if we're not bound by geography? And those are two completely different questions. Now, I've done a series of interviews recently, and one was with the Medical Economics Group in February on exactly this topic. And the most common pushback I've gotten from clinicians has not been technical. It wasn't, we don't have the tools. It was, how do I build a relationship through a screen? It's a great question. And this is a big problem for trust, and it's legitimate. The research is clear. Trust is the absolute foundation of medical care. You can have perfect clinical judgment, but if the patient doesn't trust you, they're not going to follow your recommendations. They won't be honest about their symptoms. They won't show up for their appointments. It's all about trust. So in the castles, the major academic medical centers where most people spend, their training years, you can build trust through repeated in-person encounters. You remember the patient's story, you know their voice, you can read their body language. You can build a relationship face to face. But in the field, everywhere else, you often don't have that luxury. You might see someone once or once every couple of years. You might never see them in person at all. And the question becomes, how do you establish trust in a system where presence is no longer required? It's optional. So this is where the 5 pillars become really critical. And I'm going to break this down. So first of all, from a technology perspective, we have the tech. We have video, we have secure messaging. We also have AI triage. It's there, it works. Policy. This is getting better, and telehealth prescribing restrictions have gotten extended again. And interstate medical licensing is absolutely improving, but it's still a patchwork. You can prescribe across state lines in some states, but not others. And really, there's rules everywhere you go. It's kind of absurd. Workforce. This is where we're failing. We haven't trained clinicians on how to build trust asynchronously. We haven't trained them on how to work with AI triage. We haven't trained them on how to manage continuous data streams instead of episodic encounters. Medical education hasn't caught up. Nursing education hasn't caught up. So we're asking people to do something new with a toolkit from 1995. Now, on the financing side, who pays for the time a clinician spends responding to an asynchronous message? So we do have CPT codes now, and the AMA just released 288 of them, including first ever AI-specific codes. But at the same time, CMS is cutting reimbursement for non-time-based services by 2.5%. How does that even make sense? Then there's trust, and this is the pillar that holds all the others up. And trust in virtual care is built differently than trust in in-person care. It's built through responsiveness, consistency, competence, and transparency. So if I send you a message and you respond in 4 minutes with something actually useful, I'm going to trust you more. If instead you respond 3 days later with something generic, I'm going to trust you less. Systems that have actually built trust in virtual care, and there are some, they've done it by being obsessively responsive, by making the clinical reasoning transparent, and by putting the patient's data in their hands. So I worked with a health system in the Midwest on a consulting project, and they rolled out asynchronous messaging for chronic disease management. In the first year, they only had a compliance rate of 23% because people just weren't using it. And they thought they'd failed. But when they looked at who was actually using it, it was patients with multiple comorbidities, patients who already tried to navigate the traditional system and had failed. These were the patients who had the most to lose from the status quo. They doubled down. They trained their clinicians on what it meant to respond thoughtfully to async messages. They made the clinical reasoning clear. Here's what you told us. Here's what the data shows. Here's what we think it means. And here's what we want you to do. So a couple years later, compliance rates were up to 67%. So trust is built through clarity and responsiveness, not necessarily through the camera. So here's what I think is really going on right here in February 2026. The Castle, your major medical centers, your Mayos, your Johns Hopkins, your top tier academics, they will adopt this infrastructure beautifully. They have the clinical depth, they have the IT infrastructure, and they have the funding to invest in training. So within 2 years, a patient at the Mayo Clinic will be able to send a symptom report, get triaged by AI, and see a specialist in 48 hours. The Castle will offer that, and it's going to work. Now, the field, that's rural hospitals, independent practices, community health centers in underserved areas, they're going to be stuck. They'll have the CPT codes. They won't have the financing to hire someone to manage async workflows. They won't have the IT infrastructure. They won't have clinicians trained in how to do this. And the gap will widen. And this is a central tension in healthcare right now. We have tools that could decrease disparities and improve access. But instead, we're building tools that might amplify it. The Medicare App Store might be wonderful for a patient in a major metropolitan area with a smartphone and broadband. But for a patient in rural Appalachia with intermittent connectivity, maybe an older flip phone, it's not designed for them. So in my book, I talk a lot about something I call geography is destiny. And the idea is simple. Where you live shouldn't determine what kind of care you can access. Virtual care designed right could finally break that rule. But we're not designing it right. We're designing it for the castle and hoping the field figures it out. The way you fix this is exactly what we mapped in the 5 pillars. You need policymakers who understand this. You need financing models that incentivize access and decreasing disparities, not just efficiency. And you need workforce training that reaches rural clinicians. You need technology that's designed for poor connectivity, older hardware, not just for iPhone 15 Pro users. And you need to build trust intentionally with cultural humility, knowing that trust looks different in different communities. That's not a tech problem. That's a leadership problem. So here's my challenge for you. Whatever your role is in healthcare, stop thinking about virtual care as video visits. Start thinking about it as infrastructure. If you're a clinician, ask yourself, what part of my job could I do better asynchronously? Not instead of in-person care, but in addition to it. And if you're a health system leader, ask yourself, where am I replicating the inefficiencies of in-person care on a screen? And where am I actually building something new? And for the policymakers, you should be asking, are my reimbursement models actually creating incentives for the kind of care that actually works? And as patients, we should be asking, what would I actually want from my healthcare? So the video visit was never the revolution. And I think that we're going to see that over the next couple of years. And the question will be, are we going to cross the other side of really thinking about what it can be, or do we keep walking back and forth? So everything I've talked about today is in the borderless healthcare revolution. The real virtual care revolution isn't about video. It's about infrastructure. It's about access and decreasing disparities. It's about asking what's actually possible when you're not bound by geography. So thanks for listening to The Clinical Realist. Next week, we're talking about the economics of healthcare and why it all falls apart when you actually look at it closely. This is Dr. Sarah Matt. See you next time.